Hello and welcome to Noon Conference hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access the recording of today's conference and previous Noon conferences by creating a free account. Today, we're honored to welcome Dr. Kevin Chang for a lecture entitled MRI of the Pancreas, Basic Anatomy and Pancreatitis. Dr. Chang currently serves as the Section Chief of Abdominal Imaging and Director of MRI at Boston Medical Center and Associate Professor of Radiology at Boston University Chobanian and Advesian School of Medicine, as well as Adjunct Professor of Diagnostic Imaging at Brown University Alpert Medical School. He's worked across multiple practices, health systems, and hospitals over the past 20 years in a wide variety of academic, private practice, and hybrid clinical settings, caring for a wide variety of patient populations before dedicating his current practice to the care of the underserved. At the end of the lecture, please join him in a Q&A session where he will address questions you may have on today's topic. Please remember to use that Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we're ready to begin today's lecture. Dr. Chang, please take it from here.
Thank you very much for the kind invitation to give you guys a talk about MRI of the pancreas. Usually this talk takes a couple hours. I've decided to divide it up, and the first half of the lecture that I usually give is regarding basic anatomy as well as pancreatitis. So basically non-lesions and non-malignant findings in the pancreas. These are my disclosures. MRCP was first introduced in 1991, so it's been around for many decades. Prior to MRCP, ERCP was a way to visualize the pancreas and the pancreatic duct, and 40 to 70% of diagnostic ERCPs were negative. So MRI and MRCP has largely supplanted ERCPs as well as percutaneous transhepatic cholangiograms in the imaging of the pancreatic and the biliary tree. And the advantages are that it's non-invasive, it avoids complications related to pancreatitis, duodenal perforation, hemorrhage, sepsis, and risks of sedation. It's definitely also a cheaper exam than an ERCP. It does not involve ionizing radiation, and it involves less operator skill and patient preparation. It also allows for a more accurate depiction of the ductal diameter of both the biliary and the pancreatic duct without distension using contrast. And there's a lower failure rate for MRCPs. But it does depend on patient cooperativity, and in some sequences depend on breath holding capabilities. So clear indications for MRCP include obstructions in the GI tract, esophageal, gastric, or duodenal obstructions, stricturing or edema at the ampulla of Vater, presence of periampullary duodenal diverticula can sometimes also make ERCPs more complicated in terms of trying to cannulate the ampulla. Also, post-surgical anatomy can also complicate or make some ERCPs more difficult, specifically bowel reconstructions, including choledochoenteric or pancreatico-enteric anastomoses, as well as gastrojejunostomies. And then depicting the ductal anatomy beyond or upstream from an obstructing lesion is also a great indication for MRCP. And clearly, it's a great test in patients that have had an incomplete or a failed ERCP. There are some disadvantages to MRCP, however. The spatial resolution of MRI is less than that of the fluoroscopic images obtained during an ERCP. So this can limit the visualization of small peripheral ducts. It also clearly lacks the therapeutic or pathologic diagnostic capabilities of more invasive modalities, but it can be helpful for the guidance of those kind of procedures. And oftentimes it's not as specific in differentiating malignant from benign causes of obstruction, although the use of IV contrast can help look for an obstructing mass. There are also other limitations that can reduce your image quality, especially in patients with large volumes of fluid in the abdomen, like in ascites, or in patients that have difficulty with cooperation and breath holding. And then there are a variety of susceptibility artifacts as well that can limit visualization of the ducts. So basic principles behind MRCP. Basically, the imaging is based on the inherent T2-weighted contrast between slow flow fluid-containing structures versus the background organs and soft tissues. fluids have much longer T2 relaxation times than the adjacent soft tissues, and very heavily weighted T2 weighted sequences can depict these structures with a higher relative signal intensity than the adjacent fat and organs, which have a shorter T2 relaxation time. When you image with a long echo time, it helps to suppress the background signal and increases the contrast to noise ratio of these structures. For the technique for MRI, basically, there isn't usually much patient preparation necessary, but in the elective situation, having a patient be MPO for 2 to 4 hours prior to the exam can certainly help by reducing any residual fluid in the stomach and the duodenum, allowing you to better see the adjacent ducts. An alternative can be giving some kind of a negative oral contrast agent. I think Gastromark was taken off the market, but anything else that can reduce your T2 relaxation time for fluids, such as certain fruit juices or even gadolinium diluted fluid, can also help reduce the T2 signal intensity of GI tract fluid. You can also give oxygen by nasal cannula to help patients with breath holds. And then the planes of imaging, we will usually acquire them in the axial and the coronal planes, although some of the coronal thick slab images can also be acquired using various obliquities to better demonstrate the entire length of the pancreatic duct. And we use both multi-slice thin cuts as well as thicker slab images. And then some supplementary sequences that you can use include 3D pulse sequences that acquire a volumetric volume to better depict the anatomy using thinner cuts. And there's a bunch of different techniques for the 3D volumetrically acquired pulse sequences as well, including multi-slice, 3D single shots, as well as 3D GRACE or gradient echo, spin echo hybrid type of images. Some of them are fast enough now that you can actually acquire the volumetric data set in a single breath hold. So this can certainly help in some patients that have difficulty with longer breath holds or inconsistent respiration that limit the utility of some of the respiratory triggered free breathing pulse sequences that can take a couple minutes to acquire. Basic protocols include axial single shots with and without fat saturation, coronal images, thin cuts or thick slabs, as well as we usually will acquire T1 weighted in and out of phase images just to cover the pancreas to look for the presence of fatty structures. We use diffusion weighted images as well. And then we will do an axial T1 fat sat pre-contrast, even when you're not giving IV contrast to cover the pancreas, because the intrinsic T1 hyperintensity of the pancreatic parenchyma is important to see. And then obviously we will repeat that pulse sequence in multi-phases following the administration of IV contrast when you're looking for abnormal enhancement. So in terms of planning for the images, alpha and axial plane, basically we acquire thick slab images. They can be of variable slice thicknesses to depict the biliary or to depict the pancreatic ductal tree as well as the biliary ductal tree. The thinner the slabs are, the less contamination there may be from adjacent fluid containing structures, but the less of the anatomy you're going to be able to see. There are also other techniques such as radial slab techniques where you do these multiple coronal oblique sequences to cover the entire pancreatic and biliary tree in different projections. And then for 3D volumetric acquisitions, you can do respiratory triggered pulse sequences where the slices are acquired at end expiration for each breath cycle. Or you can use some of these accelerated 3D sequences to acquire the whole volume in a single breath hold. There are various pitfalls as well to be aware of. Susceptibility artifacts will lead to loss of signal in fluid-containing structures. These could be related to surgical clips, metallic stents, the presence of gas either in the adjacent bowel or within the biliary or the pancreatic tree. It's helpful to correlate these appearances with the gradient echo in and out of phase sequences to look for evidence of susceptibility, which would manifest as blooming on the in-phase images compared to the out-of-phase images, as well as correlating to any prior studies like X-ray or CT exams. Motion artifacts can also show up in some of our images. That includes vascular pulsation artifacts and biliary flow artifacts, which can decrease your T2 signal within flowing structures containing fluid. And then you can get various pseudo-filling defects like adjacent extrinsic structures like crossing hepatic artery when you're looking at the bile ducts. The presence of intraductal debris or blood can look like filling defects in the ducts, as well as gas in the ducts, pneumobilia, or even gas in the pancreatic tree. Sphincter of Oddi contraction can also look like a stricture, so it's important that some of those thick slab images get repeated multiple times over time to try to visualize the entire tree at multiple time points to try to image between peristalsis. And then overlapping fluid-containing structures in the stomach or the duodenum or even the spinal canal or ascites can also obscure visualization of the ducts. Here's an example of an artifact, in this case, in visualizing the biliary tree. There's this big signal void here in the right hepatic tree, and on a gradient echo sequence, you can see this huge signal void affecting the right lobe of the liver. And on CT scan, you can see that that's related to a metallic clip in the porta hepatis region. So there's an example of susceptibility artifacts, which can limit your visualization of the biliary or pancreatic tree on MRI. These are some axial T2-weighted pulse sequences without fat saturation. And in this case, you can see there's a filling defect within the bile duct here within this duct. But the important finding is that it's on the antidependent side of the lumen. So that tells you that you're looking at gas rather than a stone, which would dependently layer along the dependent side of the bile duct. And then in this patient with findings of chronic pancreatitis with this beaded look to the pancreatic duct, you can see there's a loss of signal in the common hepatic duct here, which looks like it's transverse to the direction of the biliary tree here on a thinner cut, thinner slice here. You can better see that filling defect. That's a funny shape for something like a stone. And the reason for this appearance, which you can also see here on this ERCP faintly, is that there's a crossing vessel on this angiogram. So this is the extrinsic impression from a crossing right hepatic artery simulating a narrowing or a stenosis in the biliary tree. This is an example of sphincter of Oddi contraction. You can see there's a focal narrowing here in the distal CBD and an otherwise normal caliber pancreatic duct. And that's just from intermittent contraction of the sphincter of Oddi. Here's another artifact here where you can see there's a dilated pancreatic duct with some side branch radicals that are visualized here as well. And this structure over here looks like a stomach. So this is a fluid-filled stomach, which when the thick slab includes the gastric lumen, can make it difficult to visualize the pancreatic duct in that location. And the solution to that is just basically making the slab thinner or just looking at your other sequences to look around, behind, or in front of these fluid-containing structures. Next topic is going to be embryology. So it's important to realize how the pancreas develops as an embryo and a fetus to better understand some of the anatomic variations that I'm going to show to you in a little bit. So basically, your embryologic origin of the GI tract and GI structures. There's a kind of a GI tract here with little buds that start to form that will eventually become the liver and the gallbladder and bile ducts, as well as the pancreas. And the pancreas actually forms from two different buds. There's what's called the dorsal onlogon and the ventral onlogon, these two little buds here. And over the course of development, they start to branch off, and the ventral onlogon, this tiny little accessory part of the pancreas, swings around the right side and the posterior side, dorsal side of the GI tract, swings over to the posterior margin of the dorsal onlogon, and eventually fuses to form the posterior half of the pancreatic head. And then the pancreatic duct forms. There's the main pancreatic duct in the body and the tail of the pancreas. And then the duct usually the majority of the duct will drain as a duct of Wirsung here. towards the sphincter of Oddi in the ampulla of Otter. And then there's variable appearance of the accessory pancreatic duct, also known as the duct of Santorini. This is a Gray's Anatomy photo of the pancreas, and you can see here the pancreas is basically enveloped by the C sweep of the duodenum, and you can see where the ampulla forms along the medial portion of the second portion of the duodenum, and then in addition, the pancreas also uh, envelops itself around the superior mesenteric artery and vein, and the mesenteric artery and vein help to define the anatomy of the pancreas here. So in relation to the pancreas, these are the anatomic terms that we use to describe the different locations in the pancreas. We've got the pancreatic head, which is everything to the right, patient's right of the mesenteric vein. You've got the pancreatic neck, which is just in front of the mesenteric vein, the superior mesenteric vein. And then the rest of the pancreas is divided in half by body and tail portions. And then there's an uncinate process, which is posterior to the mesenteric vein as well, that tiny little the pancreatic ventral part, that the portion that used to be the ventral enlogon of the pancreas. There's also multiple ductal confluence variants that can occur. You see the smooth muscles wrapping the confluence between the common bile duct and the pancreatic duct at the ampulla of Vater. This common channel can be of varying lengths. You can have a short common channel or no common channel at all, where the ducts drain separately at the ampulla. Or you can have a long common channel where sometimes the sphincter doesn't quite envelop the entire confluence. And this can result in reflux of pancreatic fluid. At least the theory is that there may be reflux of pancreatic fluid, which can theoretically increase your risk for choledochoceles and cholangiocarcinomas, perhaps from chronic irritation of the biliary tree from pancreatic enzymes. So the major ductal variants are here. Basically, I showed you the typical or the conventional ductal anatomy, where you have most of the drainage via the duct of Wirsung, or the main pancreatic duct, and the duct of Wirsung, with variable appearances or obliterated appearances of the accessory duct or the duct of Santorini. Sometimes when the fusion of the ventral and the dorsal enlogon is incomplete, drainage can, there may be incomplete convergence of the duct of Wirsung and the main pancreatic duct. And in this case, the main pancreatic duct may drain completely by the duct of Santorini, or the accessory duct, in what's called a pancreas divisum. This is a abnormal anatomic variant seen in about 10% of all patients. Not all pancreas divisum. In fact, most pancreas divisum cases are not associated with recurrent pancreatitis, but a minority are. Literature says 20 to 45%. I think that may be on the higher side, as we increasingly recognize the how common pancreas divisum is. But this is a variant that you can see in 10% of individuals. And then when the accessory duct is tortuous, some people call this an ansa pancreaticus. I'm not sure if it's that much of a clinical relevance, but it's just an interesting finding to see with a name. This is a case of pancreas divisum. You can see the main pancreatic duct drains via the duct of Santorini, and the duct of Wirsung is separate, basically just draining the uncinate process, so as a separate uncinate duct. And the typical appearance is that the common bile duct and the pancreatic duct kind of cross over each other and don't converge at the level of the pancreatic head. And this is a 3D image showing you how they are separate. On CT also, you'll see that the pancreatic duct will cross anterior to the common bile duct and drain separately from the CBD. There is a variant of the divisum called the dominant dorsal duct. So you may have what looks like conventional anatomy, but if the majority of the drainage ends up happening via the duct of Santorini rather than the duct of Wirsung, then functionally they may function more like a duct, more like a pancreas divisum rather than just conventional ductal anatomy. Rarely, I guess, some of these patients can have a recurrent pancreatitis, in which case a dominant dorsal duct syndrome may be present. And then they call this when the duct of Santorini is a little bit more dilated than the duct of Wirsung. This can be called the Santorini seal. And then this is a little tortuous duct of Santorini, the so-called ansa pancreaticus. All right, another congenital variant that's worth describing is the annular pancreas. So if that ventral onlogon, that ventral bud of the pancreas, doesn't completely migrate around the dorsal half of the GI tract to converge on the pancreas, if it does that, but it drags some of the ventral onlogon around and there's incomplete migration, the pancreas may form a ring around that second portion of the duodenum, and this is called an annular pancreas. In this 3D image here, you can see that there's narrowing of the lumen of the duodenum, and sometimes you'll see a duct also associated with that annular parenchymal remnant of the pancreas. And sometimes you'll see that pancreatic duct, portion of the pancreatic duct encasing the duodenum as well. This is seen in 1 in 2,000 individuals, and 10% of these cases may obstruct the duodenum. They don't, most of them do not, but when they do, they often will present as a pediatric patient with this finding, or as a neonate with this finding. And it can be a cause in these cases of gastric outlet obstruction, or biliary obstruction, or pancreatitis. Here are multiple cases of an annular pancreas. I'm showing it to you both in CT here, where you can see in this minimal intensity projection, you can see there's a duct around the lumen of the second portion of the duodenum here, as well as excess pancreatic tissue around that second portion of the duodenum on these two coronal images here. And you can see this very well on MRI as well. So this is a great use of that non-contrast T1 fat saturated image, where the intrinsic T1 hyperintense pancreatic tissue is seen here to encase the second portion of the duodenum. Next topic is ductal stones. So the CBD is identified in almost every MRCP, and the sensitivities and specificities and the accuracies for depicting ductal stones, whether it's biliary ductal stones, which we more commonly look for, or even pancreatic ductal stones, is certainly much better than that of ultrasound or CT. It's now basically the initial test of choice for evaluating for ductal stones. And there's an example of a stone in the common bile duct, which looks like a filling defect distally, plus minus upstream ductal dilatation. On a thin cut, you can better see that little meniscus sign of a filling defect, a round filling defect within the lumen of the distal duct here. And when you're looking at the coronal images, whether it's a thick slab or a maximum intensity projection from a 3D single shot, it's important to realize that the maximum intensity projection images, only the maximum intensity pixels being projected forward for you to look at, and that may obscure visualization of smaller stones that are incompletely obstructing the duct. So it's still important to look at the source images in these 3D pulse sequences to identify the individual stones that may be obscured on the maximum intensity projections. Here's an example of a stone within the pancreatic duct. I suppose some of these could form theoretically from reflux in the CBD, but more commonly they're identified in the setting of chronic pancreatitis, possibly from erosion of some of the parenchymal calcifications into the duct, the calcifications that you often see in the setting of chronic pancreatitis. But they look just like a biliary stone. Here's a dilated pancreatic duct here at the pancreatic neck and head, and you can see there's a round filling defect here distally, and it'll look just like any other kind of ductal calculus. And when you're differentiating stones from strictures, basically there are some features that help you make this differentiation, whether it's in the biliary tree or in the pancreatic duct. Malignant strictures tend to look more focal, with long segments of involvement and irregular margins and maybe some asymmetric shouldering. So these are examples of some long axis and short axis views of the duct and how they might appear in both views. Whereas a benign stricture tends to be a shorter segment. It looks more symmetric and smooth and regular, versus a stone, which will look like a rounded filling defect with a meniscus sign here, and it'll look more like a circumscribed filling defect within the dilated duct on the transverse views. And there's an example of the difference between a stricture here, where you see the asymmetric shouldering and long involvement of the distal CBD versus a filling defect in the distal CBD. So the next topic, one of the reasons why I discuss stones here is because one of the main reasons why we do MRI in the setting of pancreatitis is to look for an etiology. They don't need us to make the diagnosis of pancreatitis. We don't always see the findings of pancreatitis on MRI. They clinically they'll know that the patient has pancreatitis based off elevated serum lipase and clinical presentation. But one of the main causes for pancreatitis is gallstone pancreatitis. So we're looking for the presence of gallstones, whether or not they actually see them obstructing the duct or not. But it's important to recognize the imaging features of acute pancreatitis. Typically, the hallmark is going to be peripancreatic edematous changes, the T2 hyperintense signal, either within the pancreatic parenchyma or the adjacent tissues, plus minus adjacent fluid or fluid collections. The pancreatic parenchyma itself may also appear swollen and edematous, and you may see not just peripancreatic fluid collections, but the presence of pseudocysts, or other complications, depending on how long-standing the bout of pancreatitis is. You can also look for evidence of necrosis in the form of either inhomogeneous enhancement or areas of non-enhancement. And then what MR is particularly good at detecting is the presence of hemorrhage. So hemorrhage is going to look T1 hyperintense even prior to contrast administration. And MRI is also going to be a good way to look for other alternative causes other than gallstones for a pancreatitis, whether that's an anatomic or an obstructive cause. Here's a typical case of acute interstitial pancreatitis on MRI. These two images are T2-weighted fat-saturated images in the axial and the coronal plane here. And you can see a lot of T2 hyperintense edema within the interstices of the pancreas, as well as in the peripancreatic soft tissues throughout the retroperitoneum. It looks like it's extending into the pararenal space on the left side as well. And then there's also some ascites in a perisplenic and upper abdominal distribution. And in the coronal images here, you can see a lot of peripancreatic T2 hyperintense edema surround the pancreatic head and around the duodenal sweep. On pre and post contrast T1 fat saturated images, you can see the preserved intrinsic T1 hyperintensity of the pancreas here, which does look a little swollen. And then following contrast administration, you'll be looking for homogeneous enhancement to exclude necrotizing pancreatitis. You're also going to be looking for other complications following contrast administrations. Pay particular attention to the vessels, looking for any erosion of arterial structures causing a pseudoaneurysm, or the thrombosis of other structures, especially the splenic vein and superior mesenteric vein and portal vein. Here is another typical appearance for acute pancreatitis. Here you're seeing peripancreatic fluid collections on the T2 non-fat saturated image. On T1 weighted images, you're looking in particular at the intrinsic T1 signal for the pancreas. In this case, you're seeing that there's a relative decrease in signal intensity in the pancreatic tail. And with fat saturation, you can also see hemorrhage extending anterior to the pancreatic head in this particular case of a patient with hemorrhagic pancreatitis. And following contrast administration, the lack of enhancement in that pancreatic body and tail here would show you that there's also the presence of a necrotizing pancreatitis in the body and tail as well. And yet another case here, axial T2 weighted image. Without fat saturation, it can be a little more difficult to pick up the edema that you see better when you look at a T2 weighted pulse sequence with fat saturation present. So here again, you see the edema and the pancreatic parenchyma here, peripancreatic T2 hyperintensities consistent with peripancreatic edema. And then looking at that pre-contrast T unweighted image, you can see there's a little bit of inhomogeneity in the pancreatic neck here. Better to evaluate that following contrast administration here, where it's more obvious that in that pancreatic neck area, there is an area of non-enhancement, which you can use the subtraction images to make it even more apparent, where there's a lack of enhancement, especially if there's any heterogeneity on the pre-contrast T1 weighted images, or if there's presence of hemorrhage on that pre-contrast image. It may be easier to see that on a subtraction image where you subtract the pre-contrast image from the post-contrast image. And then in that same area of non-enhancement, you're seeing some very subtle mild T2 hypointensity, which is another feature that you can see in necrotizing pancreatitis. So here, looking for non-enhancement, T2 hypointensity, as well as the other features that we've discussed in the setting of interstitial edematous pancreatitis. And yet another case here of necrotizing pancreatitis. I'm showing you a CT here, showing you the peripancreatic fluid in addition to steatosis. On the MRI, you can see that edema to even better effect. And then on the pre-contrast T1 weighted images, you can see there's intrinsic T1 hyperintense signal with a little bit of heterogeneity in the tail, kind of subtle, but much more obvious following contrast administration, where in the pancreatic body, you're seeing this area of non-enhancement, which in retrospect, looking at that T2 weighted image again, correlates to an area of subtle T2 hypointensity. And the time interval between these two images is about 2 days. So that might be one explanation for why you see the necrosis better on the MRI than you did on the CT scan. But I think because gadolinium enhancement is so much more apparent on an MRI, oftentimes the diagnosis of necrotizing pancreatitis can be easier to make on the MRI than on the initial CT. All right, another case. In this case here, I'm showing you a CT where there's relative hypoenhancement in the onset process of the pancreas here, as well as presence of steatosis on the MRI. On T2 weighted images with and without fat saturation, you can see there's a little bit of focal edema in that area, but on the T1 pre-contrast image, you can see there's T1 hyperintensity in that onset process, suggesting that if it's more intense than the regular pancreatic parenchyma, that may be suggestive of hemorrhage in that location. And then following contrast administration and subtraction, you can see that area that's hyper intense on the pre-contrast images subtracts out from the post-contrast images, suggesting that there's a small area of focal hemorrhagic necrotizing pancreatitis. Definitely something that would be easier to pick up by MRI than on the initial CT. And keep in mind that hemorrhagic pancreatitis is a more urgent finding than other cases of pancreatitis because the theory behind the hemorrhage is that it's thought to be related to vessel erosion. So the finding of hemorrhagic necrotizing pancreatitis should prompt surgical consultation and possible intervention. So that brings us to the Atlanta classification system, the revised Atlanta classification for pancreatitis. So acute pancreatitis is divided up into two broad categories. There's the interstitial edematous, uncomplicated pancreatitis, or non-necrotizing pancreatitis versus necrotizing pancreatitis. So that's the first distinction you make based off areas of non-enhancement. And then when you have fluid collections associated with the pancreas, there's further branching of these collections depending on the time course, whether it's roughly within 4 weeks of disease onset or longer than 4 weeks of disease onset, basically trying to differentiate just peripancreatic fluid collections from more organized collections, which could represent either pseudocysts or areas of walled-off necrosis, depending on whether you're talking about interstitial edematous pancreatitis or necrotizing pancreatitis. Less than 4 weeks after disease onset, these peripancreatic fluid collections are just called acute peripancreatic fluid collections, whereas when you start to see a wall forming around them and they start looking like they're more organized and potentially drainable if infected, we would call those pseudocysts. And these tend to look more T2 hyperintense and simple in appearance on MR if they're uncomplicated without infection or or other debris. Whereas in the presence of necrotizing pancreatitis, these fluid collections are called either acute necrotic collections, if it's within the earlier onset, after disease onset, or if they are more organized and walled off, that's when we call them walled off necrosis. And walled off necrosis doesn't necessarily mean they're sterile or infected. That the distinction between sterile collection versus an infected collection is largely a clinical differentiation. However, sometimes we can imply that there's a higher likelihood that a collection might be infected if we see gas collections within it, and that might be better seen on CT than MR. And both these collections can be either intraparenchymal, peripancreatic, or combined. So this is the revised Atlanta classification system. I'm going to show you an example of a pseudocyst here. When you see a fluid collection next to the pancreas in the setting of pancreatitis, if it communicates with the pancreatic duct, that's even more consistent with a pseudocyst, although you don't necessarily have to see that that appearance. 60% of pseudocysts will resolve spontaneously over time, although more complex pseudocysts, either if they're enlarging, if they're hemorrhagic, or if they're infected, some of these may require drainage, whether it's surgical, endoscopic, or percutaneous. And aspiration of these collections usually yields amylase. Here's another view of a slightly more complex case of a pancreatic pseudocyst, where you have a peripancreatic fluid collection here with a T2 dark wall and lack of internal enhancement. So next, we're going to go into some of the complications of pancreatitis. This is an ultrasound in somebody with a pancreatitis presenting with abdominal pain, elevated serum lipase, and on ultrasound, they saw what they called a mass in the pancreatic head. So this prompted further evaluation by CT. And on the CT scan, you can see there is something that looks mass-like in the pancreatic head region, with some vessels displaced or effaced along the medial margin here. And then this was further evaluated by MRI for a suspected pancreatic mass. On MR, I'll show you the, I think for one reason or other, the patient could not get IV contrast, unfortunately. But on the in and out of phase T1 weighted images here, you can see that there are some areas of intrinsically T1 hyperintense signal which look different with India ink artifact compared to the adjacent fat. And on the T2 weighted image, there's some T2 signal heterogeneity. But because of this appearance with the kind of a T2 signal heterogeneity in the center, the peripheral margin of T1 hyperintensity, which looks different from the adjacent fat on the out of phase images, the possibility of a pseudoaneurysm was raised. And whether you do it by CTA or MRA, or if you just look at your arterial phase post-contrast MRI images, you're looking for a collection or a structure attached to vessels that's consistent with a communication with the arterial tree. So in this case, this was a pseudoaneurysm of the region of either the pancreatic duodenum or GDA portion of the pancreas, and any arterial structure around the pancreas can present with a pseudoaneurysm in somebody with acute pancreatitis. Other things you'd be looking for on those MRA and MRV images or the venous phase images would be presence of thrombosis as well as in adjacent structures. And then here's another case of a patient presenting with abdominal pain on CT and MR, T2 weighted pulse sequences without fat saturation here. On the CT, you can see that there is some wispy peripancreatic fatty stranding, as well as a swollen appearance of the pancreatic parenchyma here, especially in the body and tail. You can see there's also a kind of a margin. There's a sharp encasement of the pancreatic body on the CT images, and on the MR images, you can see that the pancreatic parenchyma appears swollen. There's less of the feathery appearance that you typically see on MRI, and here there also happen to be some tiny little cystic foci, which we'll ignore. But on the post-contrast T1 weighted images here, you can see again that same appearance of peripancreatic fatty stranding, but also this sausage case appearance of this kind of enhancing capsule around the pancreatic body. And in that case, this is a patient with autoimmune pancreatitis. This is that sausage casing appearance of the pancreas is typical for autoimmune pancreatitis. I'm showing you another example here. Multi-phase CT, pre and post contrast CT here, showing you that diffuse swollen appearance of the pancreas, loss of that feathery soft tissue and fat appearance of the pancreatic parenchyma with a relative smooth margin, which shows what looks like an area of differential enhancement encasing the pancreatic body and tail here. Also shown to good effect on the MR images for the same patient. T2 fat saturated image here, you can see that sausage casing appearance on the T2 weighted images and on the post-contrast images as well. So you can see the pancreatic parenchyma here with that rind of tissue around the body and tail. So autoimmune pancreatitis, type 1 autoimmune pancreatitis is associated with elevated serum IgG4. So it is a common finding and can be the presenting finding in patients with IgG4 related disease. Keep in mind if in these cases, if you're proposing the possibility of an IgG4 related disease, there are other extra pancreatic findings that you can look for to help increase your confidence in making that diagnosis. Many of these patients can present with sclerosing cholangitis. They can also show renal pseudomasses or areas of interstitial nephritis in the kidneys. They can present with retroperitoneal fibrosis. You can see lung nodules and ground glass opacities in the lungs as well. It is basically an immune-mediated fibroinflammatory disease. The typical imaging appearance in the pancreas, which I showed you before, was this sausage pancreas with a smooth appearance of the parenchyma with loss of the lobulations and the variable appearance of this halo or capsule of tissue around the pancreas. There may be delayed enhancement relative to a normal pancreas, and there can be ductal narrowing of the pancreatic duct in these areas without upstream dilatation usually. And typically, they don't show as many pseudocysts as other cases of interstitial edematous pancreatitis and can show less relative retroperitoneal fluid and inflammation compared to other cases of pancreatitis. And if this diagnosis is being entertained, usually the next step is a trial of steroids, and then you can follow up the images to see if it improves. Here's an example of extra pancreatic manifestations of an IgG4 related autoimmune pancreatitis. In this case, this patient had renal lesions here, which can look like renal masses. It's difficult to differentiate from renal masses. They will look the ones I've seen can look hypoenhancing and diffusion restriction. Sometimes they don't look very mass-like. It could look like a bilateral pyelonephritis without the clinical features or typical symptoms of pyelonephritis. In this case, this patient also had a rind of soft tissue around the aorta in a patient with an aortitis related to IgG4 related disease. And here again, you can see T2 hypointense renal masses and a soft tissue around the aorta, as well as an enlarged prostate, which is another finding that you may see in some of these cases, prostatitis. Other areas that can be affected by this autoimmune inflammatory response include the salivary and the lacrimal glands. So you can present with a salidinitis, periorbital tissues, lymph nodes, the thyroid gland. You can present with a thyroiditis, as well as prostatitis. There are also findings that have been described in the testes, in the breasts, and in the pituitary gland. So if you can make that diagnosis based off this spectrum of findings, oftentimes you'll look like a hero, because oftentimes the radiologist is the first one to propose this diagnosis. The next topic is going to be chronic pancreatitis. So repeated bouts of pancreatitis can result in atrophy and fibrosis. An imaging characteristic for this is not just dilatation and beading and stricturing of the main pancreatic duct, but you also see more side branch ectasia. And the biliary tree may also be dilated due to fibrosis in the pancreatic head. And an MRCP is than better at characterizing moderate and advanced diseases, and not as good at being able to see earlier disease, as the side branch ectasia may be below the resolution of MRI. Is a typical example of chronic pancreatitis on a coronal thick slab image. You can see the dilated duct here and side branch radicals. Again, here, dilated pancreatic duct and biliary tree with that typical beaded appearance that's characteristic for chronic pancreatitis. And then the last pancreatic function related topic I wanted to address was secretin enhanced functional MRCPs. We don't do a lot of these, but some, rarely we will get this request to evaluate pancreatic ductal function or to better visualize the pancreatic tree by stimulating it with intravenous secretin. So it's usually given as 0.2 milligrams per kilogram dose by weight, and you inject it very slowly over 1 minute, and then you obtain thick slab MRCP images at various time points over the course of the next couple minutes, and you get kind of a time course exam here, where the pancreatic duct should dilate in a normal pancreas, and then you can also try to quantify the amount of juices that end up being excreted into the duodenal lumen to try to get a sense of pancreatic exocrine function. And then it also allows you to get a better look at the sphincter of Oddi to assess for any sphincter of Oddi dysfunction, as well as to better evaluate the rest of the pancreatic ductal tree, especially if it's a non-dilated pancreatic ductal duct. And then I think the last topic I'm going to talk about today is evidenced by this case here. So I'm showing you a CT here, very similar to some of the other cases I've shown you already before, where you've got a CT image showing peripancreatic fluid, fatty stranding, a relative area of non-enhancement in the pancreatic neck. But I'm going to tell you the presentation here is not the same as the previous cases. This patient didn't present with indolent abdominal pain. This was a trauma patient who suffered blunt abdominal trauma. So when you see non-enhancement or hypoenhancement in the pancreatic neck, especially when it's right in front of the midline structures like the vertebral body, um, you want to entertain the possibility of pancreatic ductal transection, for which MRCP is an excellent modality to better evaluate the presence of pancreatic injury, as well as the status of the pancreatic duct. So here's a T1 weighted out of phase image showing you relative hypointensity compared to the intrinsically T1 hyperintense pancreatic body. And on the T2 weighted fat saturated image here, you can see a normal pancreatic duct caliber in the pancreatic body with this area of transection, T2 hyperintense laceration through the pancreatic parenchyma. And when that laceration that you see on MRI extends to involve at least 50% of the thickness of the pancreatic parenchyma, there's a very high association with a duct laceration. So the main finding is a laceration that's deeper than 50% of the thickness. And then you'll oftentimes see the peripancreatic fluid as well, which may be related to pancreatic leaks. This is what it looks like following contrast administration during arterial and the venous phase here. You can see that lack of enhancement again, not to be confused in this case with necrotizing pancreatitis, but a pancreatic laceration involving, in this case, more than 50% of that pancreatic thickness, extending to beyond the course of the expected pancreatic duct. And then on the fixed side images, again, you can see the pancreatic duct of normal caliber and then narrowing and non-visualized in the region of injury. And this is a diagnosis that's otherwise very difficult to make clinically or even on CT. but it's an important diagnosis to make because it's associated with very high morbidity and mortality. Mortality can be up to 20 to 50% when the duct is disrupted. And oftentimes the diagnosis is delayed because of there's usually multiple other associated injuries when you do see a pancreatic duct or pancreatic laceration, hemorrhage in other organs, fistulas, abscesses, sepsis. There's a bunch of other complications that are generally seen in these kind of patients with a very variable and non-specific clinical presentation. And then that might prompt an ERCP to actually demonstrate the ductal leak directly with a contrast injection. All right, so that's a summary of my part one talk for MRI of the pancreas. We went over MRI principles and techniques. We went over a whole bunch of imaging pitfalls, particular to MRI. We went over the anatomy, not just the embryologic development of the pancreas, but ductal development and the resulting ductal variants that you can oftentimes see. We went over stones and strictures and the differentiation of those two findings on MRCP, as well as the findings of pancreatic or findings of pancreatitis, both acute and chronic, as well as various complications of pancreatitis, including necrotizing pancreatitis. We touched upon some of the peripancreatic fluid collections, as well as pseudoaneurysms. And then last but not least, I wanted to touch on the topic of pancreatic duct transections. And with that, thank you very much. I'm open to questions.
Thank you so much for sharing your lecture, Dr. Chang. Yes, we will open the floor now for any questions. If you've got a question, please pop that into the Q&A feature of Zoom so we can work through as many as we can before we need to close.
Okay. It looks like I have to stop sharing to be able to see the
Yeah, you might have to.
no, I found it. Here's
Awesome.
my box. Okay, so let's see. Multiple questions here. So someone's asking about the sensitivity of imaging findings of acute pancreatitis, CT versus MRI. I think they're both great for it. I mean, keep in mind that the goal of imaging is not to make the diagnosis of acute pancreatitis, but to evaluate for complications of pancreatitis and causes of pancreatitis, whether that's gallstones, whether there's biliary obstruction, pancreatic ductal obstruction, an obstructing mass in the pancreas, or any of the other etiologies that I showed you. I think MRI is better than CT in terms of the sensitivity for finding the inflammatory changes in pancreatitis, but I'm not sure exactly what the actual numbers are behind that. The next question would be, how would you distinguish between focal necrotizing pancreatitis and hypoenhancing pancreatic adenocarcinoma? That's an excellent question. There can be overlap. We can't always differentiate focal pancreatitis from a pancreatic mass. That is definitely a known pitfall for imaging of the pancreas. But features would be when I see focal finding in the pancreas associated with upstream ductal dilatation, especially if there's the lack of clinical findings that you typically see with focal pancreatitis, I'd be more suspicious for pancreatic adenocarcinoma in those cases. Certainly, follow-up imaging could also help. Resolution of findings, basically pancreatitis tends to be a waxing and waning phenomenon, so it should change in appearance over time. But if you have a persistent finding, especially in the absence of pain or elevated serum lipase or other features that you typically associate with pancreatitis, that would certainly raise the suspicion for pancreatic adenocarcinoma. In addition to the usual serum markers that you can run to elevate your suspicion for a focal adenocarcinoma. And then there's certainly features of pancreatic adenocarcinoma, which I can get into in a part two of this lecture, where you'd be more suspicious of an adenocarcinoma, like vascular involvement, vascular encasement, and obviously the presence of metastases. All right. So the next question is, what do you do when you find pancreatic calculi in the pancreatic head and a dilated pancreatic duct, but you don't see a tumor or or a mass in a patient who never had pancreatitis? If I'm reading that correctly, a pancreatic calculus is not a typical feature for a pancreatic mass. So if I see a pancreatic ductal calculus, I will definitely mention it, especially if there's an upstream dilated duct. It's a feature that we can see in the setting of chronic pancreatitis. I think it's up to the gastroenterologist whether it's something that they want to go in and try to fetch a stone for. I guess it depends on whether they think that the patient might improve after retrieving a stone from the duct of a pancreatic duct in somebody with chronic pancreatitis. I've seen it left behind in many cases. I'm not sure if it's because there may not be significant pancreatic exocrine function left, but it's definitely a finding I will mention to the to our referrers. Whether it gets intervened upon or not is another question. But it's not typically something I see with a pancreatic mass. A pancreatic mass, if it's associated with ductal dilatation, should look more like extrinsic impression upon the duct. And oftentimes, more often than not, I will not see the duct at the level of the mass. So there's a finding called a duct penetration sign that's been described, where focal pancreatitis may narrow the traversing pancreatic duct, but oftentimes on those thin cut T2 weighted images, you may still see a trace of the pancreatic duct penetrating through the area of inflammation, whereas a pancreatic a mass like an adenocarcinoma oftentimes will completely occlude the duct with smooth upstream pancreatic ductal dilatation, which is a different appearance than you typically see with the dilated duct that you see in chronic pancreatitis. So in chronic pancreatitis, you've got inflammation, recurrent inflammation throughout the pancreas or fibrosis or whatever the etiology of that chronic pancreatitis is, and it affects the duct in multiple locations. So you get that beaded appearance rather than the smooth upstream ductal dilatation that you'll see from a single point of obstruction downstream from the duct. And then next question is the side effects of secretin injection for MRCP. I think the main one and the reason why we inject very slowly is like it can cause nausea. We don't do a huge amount of them, so I'm not I don't often see what the other side effects for our secretin injection might be, but it is definitely a medication that's used relatively routinely in some ERCPs. So it's definitely a medication that's relatively safe otherwise to give. And then somebody asked about paraduodenal pancreatitis. Certainly, I can include that in a future lecture. I should have remembered to put a slide in on that. But paraduodenal pancreatitis, or also known as a groove pancreatitis, is pancreatitis. It's a form of mostly chronic pancreatitis that occurs between the pancreatic head and the C-sweep of the duodenum. So it's often manifests as pancreatitis, inflammatory changes in that pancreatic duodenal groove, and is highly associated with small pseudocysts in that location. So it's got that characteristic appearance, which I'll show in a future version of the talk. Let's see. Next questions. Somebody asked about pancreatic calcifications. Could this be the only feature of chronic pancreatitis? I think it can be. Don't always see dilated ducts in these cases, but typically pancreatic calcifications, especially when they're in multiple locations in the pancreas, are associated with chronic pancreatitis. Any tips for differentiating focal chronic pancreatitis on ADC and dual energy CT? Good questions. I'm not familiar with using ADC maps to evaluate chronic pancreatitis. We do have a lot of dual energy CT at my institution. I think the main feature, the main use that I use for dual energy CT is just looking or better accentuating the enhancement pattern of the pancreas, particularly on the low KEV images or on the iodine maps. I think it also is a great way to look at the vessels, especially the arteries and veins, making sure that they're patent in the setting of pancreatitis. I'm not sure if I use dual energy much in the evaluation of chronic pancreatitis. And then somebody else was asking about severity indices and grading systems. There definitely are some systems out there. I don't tend to use them, but there are multiple grading systems out there, which you can Google yourself. Um, the next question is, do pseudocysts communicate with the duct like an IPMN? And the answer is yes. When you see a cystic finding communicate with the duct, that narrows your differential down to two possibilities. One is an intraductal papillomastosis neoplasm, and the other is pseudocyst. So in those cases, the differentiation can be made based off whether the patient is presenting with pancreatitis or not. But in the absence of that kind of a history, these are the ones where at least one follow-up is warranted because pseudocysts should change over time or resolve in most cases, whereas an IPMN will persist or maybe slowly enlarge. So yes, both can communicate with the duct. Next question. So if you're unsure if an underlying pancreatic lesion is a pseudo lesion from pancreatitis, um, when is the optimal imaging follow-up? I'm not sure if I'm aware of the exact best time interval. Basically, if it's acute pancreatitis, I would follow up maybe in, I don't know, three months maybe, or maybe following resolution of symptoms. I'm not sh Some kind of a follow-up would be good. I'd have to there you could look at the there are some papers out there that will describe what the imaging follow-up time interval is, but some reasonable amount of time would be good. I don't exactly know what the best timing is. Usually, I leave that up to the gastroenterologist to decide an optimal time interval. But in the absence of an opinion from them, I would say within 3 months. And then the next question has to do with hepatocellular carcinoma, which is not relevant to this talk. And then last question is relevance of 4D flow MRI in assessing vessels of the pancreatic region. That's an interesting question. I have seen some 4D flow papers out there looking at uh, mesenteric and portal venous flow. It's definitely something that I've seen done in research. I don't know of many places using 4D flow to look at the flow patterns and especially for pancreatitis. Usually it's more for evaluation for portal hypertension, but 4D flow is not in our routine clinical armamentarium for pancreatic imaging. And then one last question here is in the pseudoaneurysm case, how can you differentiate hemorrhagic pancreatitis without contrast? So hemorrhagic pancreatitis on MRI, you can make that diagnosis without contrast on the T1 fat saturated image. We use M-Dixon. There's a whole bunch of other pulse sequences out there like Vibe and Lava and whatnot. But basically, you're looking for persistent intrinsic T1 hyperintensity um, greater than that of the normal pancreatic parenchyma. And in those cases, especially if they're associated with areas of T2 signal heterogeneity, you can raise a suspicion for hemorrhage in those cases. In fact, it's a diagnosis that I get more suspicious of on the pre-contrast images rather than the post-contrast images. Post-contrast images can often mask the findings of hemorrhage because the other structures around there, including the pancreatic parenchyma, enhance as well. So it's definitely something I see more easily on the pre-contrast images. All right, and then the last question, another last minute question here is important sequences for complicated pancreatitis, or yeah, I'm gonna interpret that as complex pancreatitis. So you want to look at all the pulse sequences. I'm assuming complicated pancreatitis, you mean necrotizing pancreatitis or pancreatitis with adjacent fluid collections. Basically, be looking at I look at the TT weighted images for fluid collections, looking for organized fluid collections, especially the presence of pseudocysts or walled off necrosis. To differentiate walled off necrosis from pseudocysts, I look at how complex the collections are, as well as what parts of the pancreas are involved. If I see fat content like peripancreatic necrosis, the fat content within some of these complex collections would tip you off to the presence of peripancreatic necrosis rather than a pseudocyst, because a pseudocyst shouldn't contain fat. Um, Other findings I'd be looking for would be the presence of gas on T1 weighted in and out of phase gradient echo pulse sequences. So if you see bubbles that look like they're blooming or looking more T2 dark on the in-phase images compared to the out-of-phase images, that would be the MR findings for gas content, although definitely it would be easier to see on a CT scan than an MRI. And then otherwise, just looking at the multi-phase post-contrast images for the enhancement pattern of the pancreas itself. So I think that was our whirlwind of questions.
I think you got them all. That was like
Yeah,
15.
rapid fire.
Yeah. Well, thank you so much for your lecture and yeah, for answering all those questions. We so appreciated you being here today.
Oh, my pleasure. Thank you very much for the invitation.
Absolutely. And thanks to everyone else for participating in this noon conference and asking such great questions. Be sure to join us next week, Thursday, March 13th at 12 p.m. Eastern, where Dr. Mylan Ho will deliver a lecture entitled A Practical Approach to Neonatal Brain Imaging. You can register for that at mrinline.com and follow us on social media for updates on future noon conferences. Thanks again for learning with us and have a great day.